Hello viewers, welcome to my channel. Me, Dr. Sanjay Gupta, a consultant gynecologist. Today's topic of discussion is PCOS. Yes, polycystic ovarian syndrome, the commonest disturbance affecting women, comprises a heterogeneous collection of signs and symptoms to form a spectrum of disorder with mild presentation in some and severe disturbances of endocrine, reproductive and metabolic function in other. A plethora of pathophysiological and genetic origins that lead to heterogeneity of the expression of the syndrome. The prevalence of PCOS in India ranges from 4 to 23% depending upon the population studied and criteria used for the diagnosis. It is most common in young adults, but it may present even in perimenopause and even in postmenopausal period. Now the diagnostic criteria. Responsibility of the clinician lies well beyond simply assigning a diagnostic label of PCOS. Rather, emphasis should be on understanding the underpinnings to the clinical picture and to long-term health implications and consequences of chronic anovulation so as to effectively address patient needs while minimizing the lifetime risks. Now, the criteria for the diagnosis of PCOS in reproductive age group. Number one is irregular periods. Women present with oligomenorrhea or amenorrhea. Number two is hyperandrogenism or hyperandrogenemia. Hyperandrogenism can occur in the form of hirsutism, that is male pattern hair growth. Next is acne. Next is androgenic alopecia. And number three criteria is PCOM, that is polycystic ovarian morphology in either or both ovaries. And the criteria is 12 or more number of follicles of diameter 2 to 9 millimeter present in either ovary, especially if it is seen by transvaginal examination. But if the examination is done by transabdominal, then the volume criteria is to be considered, which is more than 10 ml in either ovary. Now, depending upon either of the three, if either of the two is present, then the diagnosis of PCOS is confirmed. Now, permutations and combinations of these criteria can lead to many types, even 10 to 15 types of PCOS phenotypes. Now, recently, in the place of polycystic ovarian morphology, anti-Mullerian hormone label is being considered, and if it is more than 5 milligram per ml, then the diagnosis of PCOS is confirmed, but it is still under trial and not confirmed yet. Now, the spectrum of clinical manifestations of PCOS. It starts from variety of symptoms such as menstrual disturbances, infertility, hyperandrogenism, as earlier I said hirsutism, alopecia or acne, then obesity, which can be associated with acanthosis nigricans, and sometimes it could be asymptomatic as well. Now, the serum endocrinology. There may be increased androgens in the form of serum testosterone or androstenedione. There may be increased to normal luteinizing hormone. Luteinizing hormone is especially more elevated in case of lean and thin PCOS rather in obese individual where it could be in the normal range. Then elevated anti-Mullerian hormone, elevated fasting insulin, as there is insulin resistance in the syndrome, but it is seldom measured nowadays. Decreased serum sex steroid binding globulin, that is sex hormone binding globulin, increased to normal estradiol and estrone. Now, the possible late sequelae are diabetes mellitus, dyslipidemia, hypertension, and these all can lead to increased cardiovascular diseases. And last but not the least is endometrial carcinoma. Sometimes it has been said that there is increased chance of breast cancer as well as ovarian cancer in cases of PCOS, but mostly the risk is high if we consider endometrial and endometrial hyperplasia and endometrial carcinoma. Next is criteria for the adolescent age. Adolescent age, which is 10 to 19 years of age, the criteria a bit different. USG diagnosis is not needed unlike adult, as it is very common to get PCO morphology in adolescent. Now, the menstrual irregularities, which is also very common in adolescent age group, so the cycle length duration is to be changed. If it is more than 1 year post menarche and the cycle length is more than 90 days, then it is called cyclic disturbance in the menstrual period. Next is, if the cycle duration is less than 21 and more than 45 after 1 year post menarche but less than 3 years, then it is considered as irregular. Similarly, if the cycle duration is less than 21 and more than 35 days, 3 years after post menarche, then it is considered as irregular. And at the same time, if there is primary amenorrhea up to 15 years of age or more than 3 years post thelarchy, then it needs to be evaluated. Next is hyperandrogenism, that is features of hyperandrogenism. In adolescent, it is very common to have little bit of hirsutism, little bit of acne. So always the severe form is considered as diagnostic criteria, such as if the hirsutism is more than equal to 6 indices as per the Ferryman-Galway scoring, where the hair growth is seen in 9 sites. Next is acne. Moderate to severe acne only comes under the diagnostic criteria, that is 10 or more facial lesions. Then we call it as a case of criteria for the PCOS. Now, the biochemical criteria, if there is increased serum testosterone level. Now, there are 2 points to be considered in adolescent. Number 1 is UST not recommended in those within 8 years of menarche. And number 2, if the diagnosis is not clear, then it has to be reassessed after the adolescent period is over. Usually, evaluation in adolescence should be done when there is following complaints. Number 1, abnormal uterine bleeding. Number 2, hirsutism. Number 3, acanthosis nigricans, that is skin thickening, which can occur mainly at the nape of the neck. Other area can also be involved. Next is moderate to severe inflammatory acne and premature adrenarche, that is if the features of hirsutism appears below 8 years of age. Next is criteria in the perimenopausal group. If there is a history of PCOS in the early reproductive ages, then if the same features appear in the perimenopause or menopausal period, then the diagnosis of PCOS can be considered in the menopause or perimenopausal period as well. Now, development origin of the PCOS, which is known as Barker's hypothesis. In the crucial period of human development, if there is a maternal exposure to an altered endocrine and metabolic environment, which can change the programming of the fetus, it can lead to permanently altered gene expression, which makes the fetus vulnerable to childhood and adult diseases, which nothing but called Barker's hypothesis. Now, the epigenetic modifications can lead to fetal genetic susceptibility to PCOS. It may be that hyperandrogenemia from any cause arising during fetal life, that is maternal hyperandrogenism, classical congenital adrenal hyperplasia during adolescence such as premature adrenarche or non-classical congenital adrenal hyperplasia, or in adulthood, that is because of the obesity or hyperinsulinemia, induces abnormality in the feedback control of pulsatile GnRH secretion, resulting in increased LH secretion, which stimulates increased ovarian androgens in a self-perpetuating cycle. Overnutrition, undernutrition, low birth weight, postnatal lifestyle, overnutrition in childhood, central obesity, all these can lead to polycystic ovarian syndrome in adolescents and adults. So, if the mother follow lifestyle interventions to reduce the adverse endocrine and metabolic profile, there is potential to diminish the symptoms and prevent the transgenerational transmission and the dreaded disease, that is PCOS. Next is the pathophysiology. It is a complex disorder where numerous genetic variants, environmental factors interact, combine, and contribute to the pathology. There is increased LH secretion due to increased GnRH pulse amplitude, leading to increased androgen synthesis in the ovary. There is insulin resistance also, leading to hyperinsulinemia, which further amplifies the LH action, and there is increased secretion of androgen again. There is decreased sex hormone binding globulin, leading to increased bioavailability of the free testosterone. Now, the diagnosis of the PCOS. It is not a specific endocrine disease. It is a collection of signs and symptoms. No one sign, no one symptom, or no one test is diagnostic. Biochemical, clinical, and radiological components are combined to diagnose PCOS. So, number one is hyperandrogenemia or hyperandrogenism, that is hirsutism. The hyperandrogenism may present as hirsutism, male pattern growth over the face or in the body parts. Now, the acne, as we know, androgen mediates stimulation of sebum secretion, so that can lead to acne. Next is androgenic alopecia, that is female pattern hair loss, starts with the thinning of hair, then hair loss over the caput, and then in the frontal region. Number two is ovulatory or menstrual dysfunction, that is oligomenorrhea or amenorrhea. And number three, as I said earlier, polycystic ovarian morphology in either ovary, that is more than equal to 10 ml of volume or more than equal to 12 follicles in the diameter of 2 to 9 millimeter in either ovary. Recently, because of the high resolution ultrasound machines are available. So the follicle number, they are increasing to 20 or even up to 25. So if it is more than equal to 20 in either ovary, then we can stamp it as a polycystic ovarian morphology. Now here two things should be considered. Number one third normal woman can have polycystic ovarian morphology. So other signs and symptoms has to be considered and not just the polycystic ovarian morphology. And number two is 14% of COC users can have polycystic ovarian morphology. So to assess it again, 3 months break of COC, that is combined oral contraception, has to be needed, and then reassessment is done after the 3 months. Now the important thing is there are some accompaniments of PCOS. That is, number one, abnormality is in the glucose homeostasis. That is, they may have type 2 diabetes mellitus or impaired glucose function that leads to increased risk of cardiovascular diseases. There may be lipid abnormalities that leads to increased cardiovascular diseases and stroke too. There is inflammation in the body and ultimately metabolic syndrome. So after the diagnosis of the PCOS is confirmed, screening of these accompaniments has to be done. And how it is done? Oral glucose tolerance test, glycated hemoglobin test, lipid profile test, cardio C-reactive protein test, BP monitoring, waist circumference measurement to assess the central obesity or the android form of obesity. All these needs to be done during first evaluation and then periodically every 1 to 3 years after the diagnosis is confirmed. Now, next point is exclusion of other diseases. PCOS like manifestations can occur in other disease as well. So other diseases needs to be excluded. Number one is late onset congenital adrenal hyperplasia, which also presents with features of PCOS, especially if it is presented with premature adrenarche, pre or perimenarchal onset of hirsutism, or if there is familial history, or if there is ethnicity, then late onset congenital adrenal hyperplasia has to be excluded, and the test to exclude this is 17-hydroxyprogesterone, commonly occurs due to 21-hydroxylase enzyme deficiency. Number two is androgen secreting tumors of adrenal or ovarian origin. When you need to concern about this, when the hirsutism is sudden in onset, severe hirsutism, and it is associated with virilization, that is other forms of hyperandrogenism such as hoarseness of voice, muscle bulk, strength, and all these things. And if the hirsutism is progressive, that is rapidly progressive, then we need to exclude androgen producing tumor, and in that case we have to measure the serum testosterone level as well. Next is hyperprolactinemia has to be excluded by measuring serum prolactin. Similarly, thyroid disorders, especially hypothyroidism, needs to be excluded by measuring the thyroid profile test as well. Next is Cushing's syndrome should also be excluded, especially if there is clinical features of bruising, fatigue, muscle weakness, diabetes mellitus, hypertension, or cognitive impairment. Then by overnight dexamethasone suppression and serum cortisol measurement, Cushing's syndrome needs to be excluded. Next is insulin resistance syndrome, that is hyperandrogenism, insulin resistance, acanthosis nigricans syndrome. Similarly, hypogonadotropic hypogonadism also should be excluded, and idiopathic hirsutism needs to be excluded as well. Now the management part. The key points in the management is it has to be individualized depending upon the complaints and what the patient desire. The main complaint is menses abnormalities or hyperandrogenism or infertility. And at the same time, we should consider the long-term health risks as well. As before I told, endometrial hyperplasia or cancer, hypertension, type 2 diabetes mellitus, cardiovascular diseases, infertility. Now the first line approach. The first line approach for the management of PCOS is lifestyle modification. And that is the only treatment which should be started initially, and which consists of diet, mainly the low calorie diet to reduce the weight, exercise to reduce the weight, and if all these lifestyle modification does not help, then we can think of adding metformin. Other drugs which can help is orlistat or liraglutide, and the last resort is bariatric surgery. But we should go for the lifestyle modification first. Now next is for menses irregularity. Now menses irregularity can be regularized by using combined oral contraceptives. Any form of low dose, any combination of low dose oral contraceptives can be used to regularize the menstrual cycle. Now if COC is contraindicated or it is the patient doesn't favor, then we can use only progesterone, that is 10 milligram medroxyprogesterone acetate every month for 10 to 14 days, because we have to go for the cyclical menstruation to prevent the long-term exposure of the endometrium leading to hyperplasia and cancer. So to prevent that, we have to go for the progesterone withdrawal bleeding and regularization of the menses. Next is for hirsutism. For hirsutism also, combined oral contraceptive pills help, and for immediate relief, saving can be done, plucking can be done, waxing can be done, and lastly electrolysis by laser can also be tried. But if there is no improvement with combined oral contraceptive pills, then spironolactone or finasteride can also be added. Topically, eflornithine cream can be used, which is ornithine decarboxylase inhibitor, and it also works. Next is the alopecia. To relieve the alopecia, COC is helpful. Similarly, here also spironolactone or finasteride can be added if there is no improvement, and minoxidil cream can be applied locally. Now, the treatment of the infertility. The first line ovulation inducing drug in PCOS is letrozole, and if there is no ovulation with letrozole, then clomiphene or clomiphene along with metformin can be tried, and if all these things fails, then ART, that is assisted reproductive technology, helps, where GnRH and here also metformin can be combined to reduce the risk of ovarian hyperstimulation syndrome, which can occur in PCOS patients. Now, if their pregnancy occurs, then as a prophylactic measure to reduce the consequences of PCOS complications in the pregnancy, such as GDM and miscarriages and other complications, metformin can be added up to the first trimester of pregnancy in cases of PCOS. Now, metabolic and other associated health issues should be treated as well. So if there is diabetes mellitus, then oral hypoglycemic drugs has to be given, such as metformin, and if required, insulin has to be given. Next is hypertension. If there is hypertension, then antihypertensive medications has to be added. Now, if there is inflammation, if there is endothelial dysfunction, or if there is non-alcoholic fatty liver, that is acute steatotic hepatitis, then metformin can help. And if there is dyslipidemia, then statin groups of drugs has to be added. Similarly, if cardiac C-reactive protein is elevated, then ecosprin can reduce the chances of cardiovascular diseases. Now, most importantly, vitamin D status needs to be checked in evaluation of PCOS. It has been seen that vitamin D deficiency also can give rise to PCOS-like syndrome. So, vitamin D status has to be checked, and if there is deficient or insufficient, then vitamin D supplementation has to be given as per the guidelines. Now, if there is obstructive sleep apnea, then weight reduction will help. If there is psychogenic problem which can occur very commonly, then counseling, behavioral therapy, support, and if required, antipsychotic medication also has to be given. And last but not the least, endometrial cancer screening has to be done. If there is prolonged exposure, then, and if there is thickened endometrial above 12 or above 14, then endometrial biopsy has to be considered to rule out endometrial hyperplasia and endometrial cancer. That's for today, and thank you for watching my channel, and do subscribe my channel to view similar types of video in future. Thank you very much. Jai Hind.